All of you know the role of radiotherapy in the prostate cancer treatment, and it is for definitive radiotherapy or adjuvant radiotherapy and the salvage radiotherapy. And target volume according to the risk criteria, it is different. For the low risk, we usually cover the volume prostate and the proximal seminal vesicle, intermediate risk prostate and the seminal vesicle, whole seminal vesicle, and for high risk patient along with the pelvic nodes. Now, therapeutic ratio. Why hyperfractionation in the prostate cancer treatment? Therapeutic ratio is, all of you know, that is the ratio of tumor control and the normal tissue complication probability. And the improved therapeutic ratio favors trade-off between the tumor and the normal tissue. Now, LQ model, there are two parameters, alpha and the beta, which defining the radiation dose versus response curve. And these alpha beta value express the curvature of the model and also relation between the tumor and the normal tissue. And low alpha beta value tumor usually resistant to the low dose, and the value of alpha beta ratio of prostate, that is from 0.4 to 4.47. So these low alpha beta ratio is relatively sensitive to high fraction size. These are the review, that is the Profit, TEEP, Italian, and the HIPRO, and the RTOs is 0415. That has been shown that hyperfractionation is non-inferior to the conventional fractionation schedule, except HIPRO trial, which has been shown that hyperfractionation is slightly superior to the normal conventional fractionation in radiotherapy. Now, what are the objectives? To assess the treatment response and toxicity between the two arms, and to increase the treatment capacity efficiently by shortening the treatment time and potentially reduce the treatment cost. And inclusion criteria, which includes the age, patient's age more than 18 years, histopathology proven adenocarcinoma of prostate, intermediate and high risk prostate cancer patient as per NCCN definition, ability to receive the long-term hormone therapy, and international prostate symptom score is less than 15, good performance status, that is KPS more than 70, and there is no history of previous irradiation in the pelvis. And definitely patient willing to include the study and reliable for follow-up. Now the baseline evaluation, what have done, that is transrectal ultrasound guided 12-core biopsy with baseline serum PSA level. Total duration of neoadjuvant ADT ranges from 8 to 12 weeks, and baseline documentation of the quality of life, also baseline documentation of the IPSS score, and as well as before the starting of radiotherapy. Study period was August 2018 to December 2022, but sample size was collected from 2018 to July 2020, and total sample was 43. And in arm A patient, those patients who received the conventional fractionation radiotherapy, that is 24, and in arm B patient are 19 that received the 60 gray in 20 fraction. And in age group, most patients in the arm A is 13 patients is 71 to 85 years, and in arm B, 10 patients is from 55 to 70 years. And the in risk group patient, we only have taken the intermediate and the high risk patient. Intermediate risk patient was 14 in arm A and 13 in arm B. And high risk patient is arm A 10 and 6 in arm B. And grade group, most patients in the arm A and also arm B, it grade group from 2 to 3. And clinical stage, 15 patient of arm A and 17 patient of arm B in T2A to T2C. And PSA level in arm A, 8 patients were from 10 to 20 and 9 patients in arm B. And 16 patients were more than 20 in arm A, 10 patients is more than 20 in arm B. There is no history of previous pelvic surgery, and there is all patients were planned in IMRT, and radiation therapy was given 5 days per week, and all image guided treatment were given in all patients, and median time of ADT to start of radiotherapy, that is 16 weeks, and in arm A and arm B 14 weeks. And concurrent androgen deprivation therapy received all patients in both arm A and arm B. These are the volume of CTB and the PTB of target organ and the risk organ at risk. And these are the volume of the dose distribution or dose color wash of the CTV and the PTV, and also the beam arrangement. Now the right one is presenting the DVH of the conventional hyperfractionation, and the left one represent the DVH of the moderate hyperfractionation in prostate cancer treatment. It is not possible to show the how much percentage of volume, the how much receiving the how much dose. And all quality assurance is done for each treatment plan, and that is 3% for 3 millimeter. And dose constant for moderate hyperfractionation arm, that is used in EQD D2 for bladder is if node positive, in that case V30 was less than 60%, and node negative case V30 is less than 25%. In rectum case B40 is less than 50%, and 80 cc volume for B50 for bowel. All patients were followed up at 4 to 6 weeks of completion of radiotherapy, then 3 to 6 monthly, until 2 years, then annually. And patients continued to ADT therapy after completion of radiotherapy for 2 years for high risk patient, and for the intermediate risk patient that was for 6 months. And in each follow-up, serum PSA level and clinical examination was done, and other investigation according to physician's discretion were done. Primary endpoint was to time to biochemical or clinical failure, that is reported by the recommencement of an ADT, local recurrence, lymph node or pelvic recurrence, or distant metastasis. And the secondary endpoint, evaluation of acute and late toxicities according to RTOG or CTC-AE criteria, and ascertaining the overall survival and prostate cancer specific survival. Estimation of out-of-pocket expenditure involved patients in the both arm, that is almost half in the moderate hyperfractionation schedule, and of course the pre-treatment and the post-treatment assessment of quality of life. The median duration before start of radiotherapy in arm A were 16 weeks, and in arm B is 14 weeks. Median follow-up in arm A 28.6 months, and interquartile range is 25 to 36 months, and in arm B 29 months. Interquartile range is 27 to 35 months. By 3 years, biochemical failure is 83.9% in arm A, and arm B 84.3%. And toxicity, regarding GI toxicity, there is not only one in arm A and the arm B, and grade 2 toxicity in genitourinary, that is a bit high in the hyperfractionation schedule. Now we conclude that involving evidence already support the efficacy and safety of moderate hyperfraction in the management of localized prostate cancer, and we should encourage the consider timely adoption of this treatment schedule. And in the present study, efficacy of both arms are comparable in the treatment of intermediate and the high risk localized prostate cancer, and it is much cost effective both providers and the patients, and definitely reduce the healthcare burden. All of you know the radiotherapy facilities in our country, it is a silent crisis, and also it decreases the load in the in our low middle income countries. Thank you very much.